see whether it is in the vulval region. Then, especially in the labia majora, then it can be usually a sebaceous cyst. Or if the pustule-like structure is seen in the labia minora between the upper two-third and lower two-third, and if you see there is an opening or duct, then you can go to a diagnosis. It may be a Bartholin gland or Bartholinitis. So the diagnosis depend upon the location, or if you know the anatomy only, you will can get the proper diagnosis. So today we will move to these topics, especially the external genitalia as well as the internal genitalia. External genitalia mainly include the mons pubis and structures like especially the structures of vulval region. So first we will see the mons pubis. Mons pubis means, as you all know, this is pubic symphysis, and the area that is a pad of fat over this pubic symphysis is known as the mons pubis. Okay, a pad of fat covering the fat with hair and like structures after the puberty only. Before that, it will be a flat structure, and this structure you can see this is the labia majora. This area is the labia majora, and it is also a structure with a pad of fat. And after puberty, you can also see the pubic hair as well as hair structures staining on the outer surface of the labia majora. On the inner surface of the labia majora, there will be a sebaceous like glands, like you can see glands with secretions you can see. And here also these two structures, both the mons pubis as well as the labia majora, both are estrogen sensitive structures. Like only after puberty, this area will be properly visible itself. Like in a puberty girl, you can see, or a girl before puberty, like in a younger age girl before 10 or 12 years, you can only see, you can only notice structures like this labia. This is the labia minora, and clitoris will be the visible structure. These two structures will be like a flat structure. So these change the deposition of pubic fat as well as the development of labia majora are the signs of like a pubertal change. And also the hair appearance, which is also mentioned at the Tanner staging. If the Tanner staging stage, like if the hair development is of 4, then it can be, we can consider it as she is in a puberty girl, like that we can understand. Then you can see this is, as I already mentioned, this is the labia minora structure. It is like a thick fold of skin, and the lower portion is joined together, is known as, this area is known as foreshead, and the upper area, this is the clitoris, and this labia minora splits into two, and it covers the clitoris. And the area which is inner to this labia minora is known as the vestibule. The vestibule contains structures like urethra and vaginal opening, etc. And the applied aspect we can see, like in during a vaginal delivery, like this is a stage of crowning, and you can see there is a thinned like labia minora, and usually episiotomy. Episiotomy is like a planned surgical incision which is done to facilitate easy labor. Like if a planned surgical incision is usually, earlier times it was done at the foreshead level. Now it is done a little lateral, mediolateral incisions are usually preferred. If the incision is given, then it will be easy, like it is easy to suture other than tear. If tear is occur, then it will be more difficult to cure. Like depending upon the extent of tear, it can be classified into first, second, third, and fourth. Like up to, if the tear occurs up to the anal opening, it is considered as the fourth degree of tear. So if we can externally, we can see that there is like the lowermost portion of vaginal wall is also cut. Here you can see this pink color, it's like a perineal muscle, that is the muscle around this area. All are cut during an episiotomy. So we had already mentioned the sebaceous cyst, which is like a due to the infection of the hair follicle. The sebaceous cyst is commonly seen in the labia majora. Okay, this is the labia majora, and this here we can usually see in the sebaceous cyst. Then we will see the clitoris. This is the clitoral portion, and you can see clitoris here, which is analogous to the penis in male. And the difference is that the urethra is below to this clitoris. Okay, the urethra is seen below to this clitoris, and you can see this corpus, like corpus cavernosum here, and corpus spongiosum muscle. You can see corpus spongiosum muscle here, and this is the bulb of the clitoris. And there are certain conditions which is related to clitoris, like this clitoris is having so many nerve fiber ends. It is such a sensitive area. So another condition related to this clitoris is clitoriomegaly. Megaly means enlargement of clitoris. That is due to excess androgen, like hyperandrogenism. We usually hear hyperandrogenism term along with PCOS, right? In if there is this androgen hormone is usually secreted from the ascot ovary and also from the adrenal gland. If there is any like any hyperplasty of the adrenal gland, it can be a congenital also, it can be late onset also. Due to the excess androgen secretion, it may cause this clitoriomegaly. Like so many symptoms, that is group of symptoms as a result of increased that is androgen. Like we usually know there is severe hirsutism. That is the common term we usually hear associated with hyperandrogenism. Hirsutism means excess like thick hair over the like male pattern of hair seen in females. That is hirsutism. And so like frontal balding, clitoriomegaly. This group of symptoms are known as virilization. It is usually seen in patients with clitoriomegaly, patients with adrenal hyperplasia, and also certain androgen secreting tumors. Androgen secreting tumors of certain ovary may cause like Sertoli cells or Leydig cell tumor may cause excess androgen and which may even cause this clitoriomegaly. And in PCOS patients, certain long-standing PCOS with severe hyperandrogenism, they may also have clitoriomegaly. You can, if we are doing a vaginal examination, you can notice that. And in certain patients with hyperprolactemia, along with a thyroid, hypothyroidism also, if they're present with severe amenorrhea, in such patients also you can notice this clitoriomegaly. Another condition is related to clitoris is clitoridyna. Dyna means just pain only. This is a patient, she complains of severe burning sensation and severe pain in clitoris. She's having severe itching over the vaginal area. This was her clinical presentation. When doing an examination only, we identified that is as it has lichen sclerosis. Okay, in such patients, they may have severe pain around the clitoris and severe pruritus. Pruritus means severe itching. She even have sleepless night during this due to this pruritus. Okay, and also in certain patients with pudendal nerve. Pudendal nerve supplies this area of this perineal area and this vulval area. So, if there is some like pudendal nerve injury, it may cause severe pain in the clitoris as well as in the vulval region. Then the another condition is vulval pruritus. Pruritus we had already mentioned, like severe itching. Some of the most common causes like vulvovaginal candidiasis. Candidal infection is one of the most common patients that we get in our OPD. And also at almost 75% of women may have this vulvovaginal candidal infection at some point of their time, so at some point of their lifetime. And also certain conditions like bacteria vaginosis, trichomonas all contribute to vaginal pruritus. Pruritus means itching in the vagina. And also in patients with diabetes mellitus, they may have more chance of this pruritus, or they have recurrent chance of this vulvovaginal infection. And also in menopausal women with atrophic changes, they also have this pruritus. Next, we will move to the vestibule. Vestibule of vulva. Vestibule means the area. You can see this is the area which is inner to the labia. This is the labia minora, and the area inner to the labia minora is the vestibule of the vulval region. So in the vestibule, you can see this urethral opening and the opening of Skin's gland around the urethra. This is the vaginal opening, and you can also see the opening of the Bartholin's gland. This is the Bartholin's gland. The location should be remembered. It is situated on the between the upper two-third and lower one-third of the labia minora, and this is a small peanut-shaped gland, and the duct, like it is a small duct between 1.5 centimeter And the opening of duct is also 0.5. It is a small opening. We cannot visible it unless there is a infection. Only we can see it. Otherwise, we cannot see it. Vulvodynia is also another condition with pain in the vulval region. In some perimenopausal women, they usually, like in a menopausal symptom, lady, they may usually come with severe burning, like burning type of pain in the vulval region, and also in patients with vulval varicosity, like we also know now varicosity on legs, like that there is a possibility of varicosity around the vulval region, especially in pregnant ladies. You can see this type of vulval varicosity. At least in 18 to 22% of pregnant ladies may have a possible chance of developing this vulval varicosity. In such type of patient, they may have like aching pain or even burning type of sensation in the vulval region. Now we will see the Bartholin's gland. Bartholin gland we had already see. It is situated in the 5 o'clock as well as in the 5 o'clock as well as in the 7 o'clock position. The duct of the gland open into the vaginal opening. Okay, the main aim of this gland is to provide mucus secretion, especially during the sexual excitement. This Bartholin gland, there is a chance of infection to this Bartholin gland, infection or inflammation. So that is known as Bartholinitis. Itis means inflammation. It can be either due to staphylococcal or streptococcal infection. There is a chance of Bartholin infection. And due to this, there is a gland and there is a duct. Okay. If the duct is infected and the duct is occluded, like the duct is closed, so then what happened? This gland began to enlarge. Okay. You can see this gland started to enlarge. Then it becomes a Bartholin cyst-like structure. If again this gland began to enlarge, what happened? The body tried to expel the secretion out. Then it become Bartholin abscess. Then there will be some opening will be formed. Then there will be pus will be excluded like that. So if a patient comes to you with, then there is marsupialization. That is opening of the cyst and draining of the pus is done first. Another condition related is with the vulval or vaginal opening is an imperforate hymen. Hymen is we know a delicate incomplete membrane. Incomplete. There is some opening in the hymen which allow to the flow of menstrual bleeding. So if what happens if it is a complete closure of this vaginal opening, then if a normal like normal menstruating woman, but then what happen? Then the fluid, the menstrual fluid and menstrual debris will collected in the vagina. Okay, so this imperforate hymen is it's caused due to the failure of disintegration of Mullerian duct as well as urogenital sinus. The Mullerian duct means the two Mullerian ducts joined together to form the fallopian tube, uterus, and the upper portion of vagina. From the lower portion, the urogenital sinus develop. It contributes to the lower portion of vagina and this hymen and structures. So if there is defect in the disintegration of the central cells, it may lead to the imperforate hymen. So as the girl become the menstruating and she may not have a visible manifestation. Menstruation means a visible manifestation of. Due to this imperforate hymen, there may not be a visible manifestation, and the cyclic menstruation becomes collected in the, if vagina it is collected, it is known as hematocolpus, and after the vagina gets filled, later it becomes the uterus become collected, then it becomes hematometra, and after that, if the fallopian tube gets collected, it is known as hematosalpinx. So in such type of patients, when we are doing an examination, of we doing an inspection, we don't do a PV, we'll see an inspection. We can see this income, the hymen becomes bulge and its color turns to blue. Like this much of fluid is collected inside, and so it may cause like bulging. In such type of patient, we can do a perrectal examination. During a perrectal, we can feel that there is a bulging of the vagina, and the main thing is we had to do a cruciate incision. Like if this is a closed vaginal membrane, and he had to do a cruciate, like a cross like incision, and to drain the like menstruation and debris. So at that time, PV is not indicated, it is contraindicated because there is a increased chance of infection. And also USG also, Per rectal examination and ultrasonography also help to identify the condition. Then the vulva is mainly supplied by the pudendal artery and it is drained into and the venous drainage is mainly into the internal and external pudendal vein. The lymphatic drainage is mainly by the superficial inguinal and deep inguinal lymph nodes, and mainly the vulval region is supplied by the sensory fibers of S2, S3, and S4 pudendal nerve. So, if some patient with pudendal neuralgia, we heard about the trigeminal neuralgia. Trigeminal nerve, this supply the face and all. Due to trigeminal neuralgia, there is severe pain on the cheeks, eyes, and like that. Like that, if there is pudendal neuralgia, there will be severe pain on the the vulval region is the main area which supplied by the pudendal nerve. So there will be pain around the vulval region. So there are also so many conditions related to vulva like vulvar intraepithelial neoplasia, vulval CA, vulval lipoma. There are already so many conditions related to this vulva. Next, we will move on to the internal genitalia. Internal genitalia, especially, will start from the vagina. As you can see in this picture, vagina is an elastic fibromuscular structure. This is the vagina portion, and it forms an angle of 60 degree. Like this is if the long axis of vagina, and if you are taking the long axis with here, you can see there is a. Dr. Jasul, am I audible?
Yeah, audible. You can continue.
Hello. Yeah. Okay. 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 Thank you. The long axis of vagina makes an angle of 60 degree with the horizontal axis. And you can also notice that the anterior vaginal wall is much lesser than posterior vaginal wall. The anterior vaginal wall is almost 7 centimeter and the posterior vaginal wall is almost by 9 centimeter. And the diameter is by, you can see that in the lower portion, the diameter is less, and in the upper portion, there is much wider region. And it is also an area, it is a connection between this from the external genitalia through the vagina, through the cervix, through the fallopian tube. There is a connection to the peritoneum. So it is a connecting pathway. So if then here the vaginal pH should be maintained, so that vaginal pH is usually acidic. The main aim of this acidic pH is to prevent the entry of microbes, because if the microbes can enter, it can reach up to the peritoneum. So the vaginal pH is maintained acidic. So mainly the acidic pH of vagina is between 4.5 to 5. It is mainly with the help of estrogen hormone, because before puberty and after menopause the vaginal pH is alkaline only. During the reproductive phase only the vaginal pH is acidic. So estrogen is from the vaginal mucosa or from the vaginal squamous cell secretes glycogen. This glycogen is converted into lactic acid. Lactic acid by the Doudrellus bacteria. Doudrellus bacteria is a vaginal flora friendly bacteria. It is usually present in the reproductive age only. After menopause, after the secretion of the after the estrogen is stopped, then the Doudrellus bacteria will be absent in the vaginal flora. You can also check the vaginal pH with like litmus paper, like this much long yellow color litmus paper. You can check the vaginal pH. Another thing is vaginal fornices. Vaginal fornices means the area which is around the cervix. That is, the cervix has a vaginal portion also. Cervix is the lowermost portion of the uterus. The cervix has a supravaginal part, that is the part above the vaginal portion, and a vaginal portion also. That is almost 1.5 centimeter of the cervix is in the vagina. That is this the vagina, and the cervix is like this. So the area around the cervix in the vagina is known as fornixes. So we can classify the fornices into anterior and posterior and also lateral fornices. If you are doing a speculum examination, you can clearly see the fornices. And you can sometimes see if the patient is having some discharge, vaginal discharge, cervicitis, you can see the secretions around this. You can in the fornices, especially in the posterior fornix, you can see the secretions collected. This is the posterior fornix. You can see the secretions collected in the posterior fornix. The posterior fornix is more deeper than the this other two. And another thing we can clinically we can do if you are doing a PV, If you are doing a PV, especially in the lateral, on the lateral fornixes, if the patient is thin or if the patient is having a PCOS or enlarged ovary, you can feel the ovary with your vaginal hand on from the, and also another hand on your abdomen. If the patient is lean and if the ovary is somewhat enlarged, you can feel it in the vaginal fornices also. And also doing a transvaginal sonography, during the transvaginal, when the transvaginal probe is inserted, like the long probe which is inserted, and this probe is inserted into this area, this probe is deviated to this area to get a clear picture of the ovary. Another thing, we'll move to histology of vagina. The vagina has mainly three layers: the mucosal layer, the submucosal layer, and the musculosal layer. And the muscular layer. Muscular layer have inner circular fibers and outer longitudinal fibers. And another thing is a fibrous coat. Here it's a fibrous coat, which is by the condensation of the endopelvic fascia. There are so many fascias here. From the condensation of the endopelvic fascia, it gives a fibrous structure. This vagina is very much like a stretching like structure because it facilitates the normal delivery. So it had to stretch. It's an organ of copulation, and also it is a like track to pass the menstrual bleeding, and also it is a like fibrous like stretching type structure. And the supports of vagina we will discuss along with the supports of uterus. Then it will be easy to understand the prolapse. Another thing, this picture you had to keep in your mind. You had to remember this picture because it will help you to get a good idea about the structures. Okay. This is a, as you can see, the uterus is an antivater and antiflex structure. This is a bladder, this is a rectum, and this is the peritoneal layer. Okay, this is a peritoneal layer which is covering the anterior and as well as posterior surface of the uterus, and this is a deeper up to the vaginal layer, and it reverts back. This is the utrovesical. Bladder is known as vesicle. This is a utrovesical pouch. This is a utrovesical pouch. Okay, this is a small pouch, and this is the recto-uterine pouch. Recto-uterine pouch. This is somewhat a deeper pouch, and it is the most dependent area. We can see that the most lowermost portion of the area. So if there is any secretion or something, it will be easily collected in the recto-uterine pouch. This pouch is also known as cul-de-sac also. Like if you're doing a follicular study, we can when the ovulation happens, you can see that the in the report you can see that the fluid is seen in the POD. Fluid is seen in the pouch of Douglas. This is the pouch of Douglas. Okay. And this vaginal wall, this is the anterior vaginal wall. We had already mentioned that it is almost 7 centimeter, and this is the posterior vaginal wall. So you can see the anterior vaginal wall is related to the posterior surface of the bladder. Okay. This thing you have to remember, this is related, the upper two-third is related to the posterior surface of bladder, and the lower portion is related to the urethra. Likewise, the posterior vaginal wall, it is related, and upper in the upper one-third is related to the recto-uterine pouch. Middle portion is related to the rectum, and the lowermost portion here is a perineal body. See, so if the vaginal wall gets laxed, if there is the supports of the vagina is reduced, or if the support is lax, then there is a possibility of the bladder to protrude into the vagina, into the upper two-third of the vagina. And if the anterior vaginal port lower portion is lax, then this urethra will be protruded here. Likewise, if the posterior upper one-third, then there will be like this portion, cul-de-sac, along with intestine coils are present in the sac. So it can be protruded here. If the middle two-third is lax, then it can be rectum can protrude into the vagina. Okay. So, moving to the applied aspect, as we had mentioned, when the upper one-third is lax, we can see the bladder can be protruded. This condition is known as cystocele. If the urethra is protruded, then urethrocoele. Okay. If rectum is protruded, then rectocele. If from the cul-de-sac, the intestine coils are protruded here, then it is known as enterocele. If a lady after this vaginal hysterectomy, then if vaginal hysterectomy like that, if I'll show you something. This is the vaginal wall. This is the vaginal wall. Okay, this is the vaginal wall. After hysterectomy, this portion is blindly folded. Okay, because uterus and all things is removed, only the vaginal portion is laxed. If the vagina is not properly lied to the surrounding structure, then what happens? This portion will be folded back and it will comes to the lower portion of the vagina and even comes out. This is known as vaginal wall to prolapse. Wall means the ceiling, vaginal wall to prolapse. And another thing is uterine prolapse. Uterine prolapse also I will show.
Excuse me, doctor. Can you off the screen share so that we can we view you better? Okay.
Okay, okay, then I will stop. Stop screen sharing. Okay.
Yeah, it's okay.
I will. Shall I repeat it again?
Uh, okay,
No
okay.
need. Na? Okay. This is a vaginal wall. If this vagina and if this after hysterectomy, this portion is like sealed so that there will not be any entry of any organisms into the peritoneum. Or there may be a chance of peritonitis. So this portion is sealed. So if this area is supported to the nearby structures. So what happens if there is supports is if it is not supported well, then this area is will be due to pressure or gravity, it will come out. This is vaginal wall to prolapse. Another thing is uterine prolapse. This is the as I will also show. This is the vagina, and this is the uterus. This is a normal antevertebral and anteflex uterus. Only my hand. This is a normal antevertebral and anteflex uterus, and it is usually placed in the vagina like this. The cervix portion is into the vaginal portion, and it is situated like this. So when the supports of uterus is less, then what happens? It will this vaginal portion, this uterine portion will be descend into the vagina, like first degree, second degree, third degree. When it comes out, it is known as presidentia. Okay, is it clear?
Yeah, yeah. Carry on.
Shall I share the screen? Okay. This is a image of cystocele. Here I am using a thin speculum. Thin speculum means Cusco speculum is a bivalve speculum so that we can like we can open the both vaginal walls and we can see the cervix. With the sim speculum, I can easily retract the posterior vaginal wall. So I can see the cystocele like bulging of the bladder into the vagina. I can see it clearly. You can see also this is the cystocele. Then now we will move on to the blood supply of the vagina. Vagina is mainly supplied by the vaginal artery. As you can see, this is abdominal aorta. Abdominal aorta split into common iliac artery, then common into internal and external iliac artery. From the internal iliac artery, vaginal artery develop, and vagina get additional supply from the cervico-vaginal branch of uterine artery and also from the middle rectal artery and internal pudendal artery. It also get additional supply, and the venous drainage is mainly into the internal pudendal vein. Then lymphatics, it is mainly from the inguinal lymph nodes, is mainly drained to inguinal lymph nodes, and nerve supply is by the pudendal nerve. So we had already mentioned that is vagina is developed from the mullerian duct also and partly from the urogenital sinus. So there is two mullerian ducts which join together and it forms the uterus, fallopian tube at the lower portion of the vagina. Sorry, and the upper portion of the vagina. And the lowerly it is developed from the urogenital sinus. In certain patients, it's a rare condition, there will be agenesis of vagina. Agenesis means agenesis, that is absence, complete absence, or even partial. That is partial means like the either it may be their lower one third or upper one third portion is usually absent. So complete agenesis is usually associated with complete absence of uterus also. It is a developmental defect, like it is known as Mayer-Rokitansky syndrome. It is rarely seen, and like failure of vertical fusion. Vertical fusion means upper and downward. That is the from the upper portion developing and lower portion developing. When there is failure of vertical fusion, there will not be any continuity in the structure. If the failure of lateral fusion means the failure of joining of these two like Mullerian ducts. Okay, if two Mullerian ducts join together, like two Mullerian ducts join together, and it forms a single structure, uterus along with the fallopian tubes. So what happens if this there is some defect in the fail in the joint? Then there will be like a bicornate uterus with two horns, bicornate uterus, or even there will be septate uterus, depending upon the defect in the development. So you can see it clearly. This is the gonads, this is the Mullerian duct. Okay. So in the vagina, we can see from the posterior fornix. This is the posterior fornix. This is the pus like this collected here. Then or some blood or some secretion like that. You can take this skull synthesis. You can take a sample. You can take a like you can apply a cuscos, and then you can open the cervix and you can insert a needle through the posterior fornix. Okay, this is the relevance of posterior fornix, and you can take the sample from here and you can test it. And also nowadays, the oocyte retrieval as a part of IVF treatment, oocyte retrieval is usually done from the posterior fornix. And another thing is pudendal nerve block. Like in vagina, when we are doing a PV, we can easily feel this ischial spine. You can see this is the ischial spine. You can easily see this. If you're doing a PV, you can easily feel the ischial spine on the lateral aspect. So this is the ischial spine. From the ischial spine, you can a little lateral, you can feel the sacrospinous ligament also. Some like tendon like structure. If you're applying pressure, you can feel the like a tendinous rigid structure. So back to it is the pudendal nerve. So giving like anesthesia or pudendal nerve block, this is the like this the landmark using is the pudendal nerve, and it is usually done with the lateral fornix. Another thing is related to vagina is vesico-vaginal fistula. We had already heard about fistula related to the anal structure. Vesico-vaginal, vesico means bladder, and vagina vesico, there is an abnormal connection between bladder as well as vagina. Okay, in it is commonly seen. It can be a congenital cause also in patients with prolonged labor. If there is a history of prolonged labor due to the pressure exerted by the head of the fetus, there is some chance of necrosis of this area. Necrosis of this area, and due to the necrosis, there may be an abnormal opening, of course. If the patient complains with like secretion, constant secretion from the vagina with a urine like smell, then if you're suspecting a vaginal like vesico-vaginal fistula, like a test is like that, you had to put like cotton balls in the vagina, like in three cotton balls, mainly in upper one third, lower one third, middle one third, and lower one third. You had to place three cotton pads, and you had to insert methylene dye into the bladder, and you can check whether these swabs whether they gain this blue color. Then we can be easily diagnose this vesicovaginal fistula, and also we can see which area it is affected, like in the middle part or the upper one third. Like that, we can easily identify. Then vaginitis also, it is some of the common issues we will get, like it can be a trichomonas vaginitis or candidiasis or atrophic vaginitis. It is usually identified depending upon the color, whether it is like a yellowish color or curdy like color. Depending upon the color and texture, we can identify which organism is behind it. Now we will move to uterus. Uterus is like a childbearing structure. It's according to our classic Garbhashya Garbhadara. It's considered as an ashya. Garbhashya is mentioned, which means a cavity only. It is a term which we also use to mention uterus also. It is measured about like 7.5 into 5 into 2.5. This measurement you had to remember, because on USG, if we see this measurement, you had to know what is normal. Then only we can identify whether the uterus is small or even in bulky uterus, the measurement may change. So the normal measurement should be kept in mind. Okay. Then the uterus is between the bladder and rectum, that is Pitta Padkoshya Madhya, and the pelvis is concerned to the pelvis. It lies in the true pelvis, that is within this area this uterus is placed. And the main function of uterus is to provide protection and nourishment to the fertilized ovum, and also it has a strong muscle it provides a severe contraction during the labor, and it help in the expulsion of the fetus also. The shape of uterus is mentioned like piriform in shape, and in our classics, Rohita Matsya Mugagaram, Alpamuham, like Alpamuham under Mahasushram. That is, the cervical opening is small and the uterine cavity is big, like that. Alpamuham under Mahasushram, Changanabhyagriti, like in the shape of a conch shell, it is mentioned. So the uterus is divided into mainly three parts, like the body of the uterus, the isthmus, and cervix. The body of the uterus means it is again divided into this area is the corpus area. Corpus means fundal area. That is the area above the opening of the fallopian tube is known as fundus, and below that it is known as the body proper. The isthmus area means the area between the anatomical internal os and the histological internal os. This is the area of isthmus. It is a very small area, almost zero point 0.5 centimeter, and the lower portion is the cervical area. This is about 2.5 centimeter. This almost half portion is above the vagina, and the half portion is into the vagina. So cervix is the most elongated part. The cervical secretion is usually alkaline secretion. As we know, the vaginal secretion is acidic secretion, but the cervical secretion is alkaline secretion. The main intention, it favors the penetration of the sperm. Okay, and also the cervix acts as a sphincter, especially in after pregnancy, after the uterus become pregnant and the uterus, the baby start to grow, the lower portion of the uterus or the cervix is like acts like a sphincter. It holds tightly the baby. Okay, and especially one more thing, the cervix also have a secretion. The cervical secretion is, if the cervix secretions get infected, it's known as cervicitis. And the cervix is, inner cervix is like columnar epithelium, and the outer of the cervix is squamous epithelium. So the squamo-columnar junction, that is between the outer and inner surface of the os, there is relevance because there is more chance of developing cervical intraepithelial neoplasia in this area. So this area is somewhat important. So this is cervical incompetence. Incompetence means it is not capable of holding it tightly. So if you're seeing a USG of a pregnant lady, there is always a measurement of cervical length is measured. The cervical length is measured. The cervical length 2.5 is mentioned. If the cervical length is reduced, then there is a more chance of like opening of the cervix, and there's more chance of like abortion is there. So this is usually seen in the second trimester. If a lady had an issue of this like cervical incompetence, and her baby is she got an abortion because of this cervical incompetence, next time on the next pregnancy, before the like that, before 10 or 12 weeks, she will be advised her cervical encirclage. Encirclage means like it is like tied, it's tight, and make sure that it stay in position. That is cervical encirclage. Another thing is we will see the position of the uterus. The position of uterus is normally anteverted and anteflex. This is the anteverted position. That is the long axis of vagina with the long axis of uterus makes this angle of anteversion. Okay, anteversion, the angle is 90 degree. Anteflex means the uterus flexed on itself. That is the angle of anteflexion. This is the angle of anteflexion. It is only 125. Here it is written wrong. It is 125 degree. This angle of anteversion and angle of anteflexion is maintained mainly by the two ligaments. One is the uterosacral. The name itself says the uterus is like tied to the sacrum, the uterosacral ligament. Here will be the uterosacral ligament. And another thing is the round ligament. The round ligament is from the corner of the uterus. Corner of the uterus means where the fallopian tube is attached. From the corner of uterus, it is pulled like this. And here the uterosacral ligament pulled it like this. And this pull from both sides make the uterus in this position, angle of anteverted and anteflex. There is some variation from that also. Some ladies, that is especially 10 to 12 like percentage of ladies may have retroverted uterus. Retroverted uterus means uterus may either stand up or inclined to back. This is retroverted and this is retroflexed position. Now we'll see the layers of uterus. The uterus mainly have three layers. Like this is the endometrial layer, myometrium, and this outermost layer is the perimetrium. This perimetrial layer is usually contributed by the peritoneum. That is, peritoneum around the uterus contribute to the this peritoneal layer. That is, there is also a classification related to Jarayuna perividum. That is covered with the jarayu or the membrane like peritoneum. So that we will see each by each layers. Now we will see the endometrium. The endometrium consists of lamina propria as well as surface epithelium. The endometrium has mainly two layers. That is, we all know the stratum basalis and stratum functionalis. The functional layer which shed during each menstruation. So this surface epithelium consists of ciliated columnar epithelial cells, and lamina propria contains endometrial glands, stroma, blood vessels, nerves, etc. These undergo cyclic changes under the influence of estrogen as well as progesterone, which are secreted from the ovary. So, myometrium is the middle layer, which is the middle muscular layer. It contains the outer longitudinal muscles and middle interlacing. Interlacing means crisscross muscle. There are so many blood vessels in between this layer. So, if during a normal labor or during menstruation, if the uterus contract, then there will be like stoppaging of bleeding. That is, it is known as the leaving ligatures. And the inner is a circular line. But from this, the clinical aspect is that from the myometrium, this fibroids arise. From the myometrium, this fibroid arise. So we have already heard the classification of submucosal, intramural, subserous. Such type of classifications are commonly seen. So submucosa means which is near to the mucosa. Usually it occurs. Usually the fibroid arise as a like a intramural within the muscle only. When the fibroids start to grow, it pushes into the inner side of the membrane, like near to the mucosal layer, then it is known as submucosal fibroid. If it is pushed out, then it is known as subserosal. Sometimes you can also see pedungulated, like it is pushed that much very, it is pushed out and covered by the peritoneal layer, then it becomes a pedungulated fibroid. Another thing is perimetrium. Perimetrium is outer covering of the uterus, like the peritoneal covering. This outer perimetrium is contributed by the peritoneal layer, which contribute to the uterovesical pouch as well as also rectouterine pouch. And one more thing is that this is like the uterus, and it is covered by this layer. And this is the anteriorly it is the uterovesical pouch and posteriorly it is the rectouterine pouch. Then what happens? This lateral two layers fuse together to form the broad ligament. Okay, this lateral two join together to form broad ligament. Anteriorly the uterovesical pouch, posteriorly rectouterine pouch or the pouch of Douglas. Laterally it forms the broad ligament and it is attached to the lateral pelvic wall. The uterus is mainly supplied by the uterine arteries, and ovarian artery also contribute to the blood supply of the uterus. So the blood supply you can see this is the ovarian artery and the uterine artery anastomosis, and it enters as like that. Here you can see it more clearly. It enters as arcuate artery in the muscular layer, and later it gives rise to radial artery. This radial artery also give branches to this endometrial layer, like spiral artery and basal artery. Basal artery supplies the basal layer, that is basal layer of the endometrium, and this to the superficial layer. So you can also identify this the anterior vaginal wall. This uterus is related anteriorly to the bladder and the uterovesical pouch, and posteriorly to the pouch of Douglas, and laterally to the broad ligament. Now we will see the supports of uterus. This is an important question. supports of uterus, we can, for easily understanding, we can classify the supports of uterus into mainly into three, like like three tires in train, like three seats in train. Like that, we easily classify it into three tire support. One is up to this area. This we can already see the anterior utrovesical pouch or utrovesical fold, or is also known as anterior ligament. Anterior ligament. Here it is posterior ligament, and laterally this is the broad ligament with support to the lateral pelvic wall, and also the round ligament. Round ligament from the corner of uterus, it is like forward pull. So these contribute to the upper tire. One more thing is the anterior ligament, posterior ligament, and the lateral ligament, as well as the round ligament. This is the first tire support. Second tire means the area around this area. Support is known as second tire, like the transverse cervical ligament. Transverse means cervix, the connecting the cervix to the lateral walls, or the transverse cervical ligament, or McEnroe's ligament, or cardinal ligament. These are three names for the transverse cervical ligament. And other thing is uterosacral ligament, like which connect uterus to the sacrum. Sacrum, here it is uterosacral ligament, and pubocervical in the pubic symphysis to the cervix. That is pubocervical, uterosacral, and transverse cervical. These three contribute to the second tire. And the third tire related to the pelvic diaphragm or pelvic floor muscles, and also the urogenital diaphragm here. This contribute to third tire, third level of support. So these supports of uterus and vagina is important for it retain it in a normal position. So when the support gets lax even after this prolonged labor, or even by birth there is a weakness of the pelvic floor muscle, then there is a more chance of like cystocele, rectocele, urethrocoele, or even uterine prolapse. So anterior ligament we had already mentioned, this anterior ligament, posterior ligament, or rectovesical fold, broad ligament. Broad ligament, the lateral pelvic peritoneal fold with support to the lateral pelvic wall. This is the broad ligament. And the broad ligament in the upper portion, this is known as infundibulopelvic ligament. It supports the fallopian tube also. And the broad ligament is again classified into mesosalpinx. That is the area below the fallopian tube is known as mesosalpinx, and below to the ovary ligament and all this thing is known as mesometrium. There are so many structures passing in between the two layers, the two folds of the broad ligament. One is the uterine artery and the ovarian artery, the anastomose here. Then you can also see there are certain remnants like para-oophoron, oophoron. These are like the embryological remnants of the Wolffian duct. Two ducts are there, Wolffian duct and Mullerian duct. Mullerian duct develop into female structures, and Wolffian duct develop into male structures. So if the baby is genetically determined to develop into a female child, then the Wolffian duct disintegrates, and the remnants is seen in the broad ligament. No, that's a round ligament. The round ligament is like a guy rope structure, that is and pulls and holds the uterus friendly. That is this attached from the corner of uterus. It passes through the deep inguinal ring, then it passes in between the muscle layer, and it passes through the superficial inguinal ring, and it reaches the labia majora. Okay, this much goes from the deep inguinal ring, reaches the superficial inguinal ring, and reaches the labia majora. Like this, it passes through the inguinal canal. It supports the angle of anteversion of the uterus. So, in embryologically, like if a male, this is known as embryology, this is known as gubernaculum. Like the testis is directed to the like scrotum. This gubernaculum helps in the movement of this gonads into the scrotal area. So this labia majora is a structure homologous to the scrotum in males. So by in a female, when the female gonad or the ovary, it reaches its position, then this gubernaculum is like change into a fibromuscular structure. That is when it becomes the ovarian ligament. Ovarian ligament, it attaches the cornea, a corner of the uterus, and the remaining portion it becomes the round ligament. It holds the uterus, and it supports the angle of anteversion also. In pregnancy, there is one clinical issue, that is in some patients, if due to the stretching of the abdomen, you can see the abdomen is stretched, and in some patients, in not some, in most of the patients, they may feel some vague aching pain in the this like in the inguinal region, they may have pain, and some patient may also have severe like pain is usually felt in the labia majora also, because of the stretching of the round ligament. They may have this pain over the inguinal region and also in the vulval region. So if we know the anatomy only, we can tell them, no, this is due to the this due to the pull of the round ligament. So inguinal canal means as there are mainly four muscles in the anterior abdominal wall. One is the superficial oblique muscle, then transverse oblique, external oblique, internal oblique, transverse oblique, and then the six pack muscle, the rectus abdominis muscle. So this superficial inguinal ring is a triangle like opening which is seen in the external oblique muscle, and deep to that is internal oblique, and deeper to that is the transverse abdominis muscle. So the deep inguinal ring is an opening in the transverse muscle. So in between these muscles there is an oblique passage. This is known as inguinal canal. So this inguinal canal, in males, spermatic pass through the inguinal canal. In female, round ligament pass through the inguinal canal, and it reaches the labia majora. Then we will see the second tier of support, like we had mentioned. This is some McEnroe or cardinal ligament. Transversely, it is supporting. Then this uterosacral, this is sacrum and uterosacral ligament. This pubocervical ligament. These supports the second tier. This is second tier of support. And the thing is the pelvic floor, which is the major supporting area, the pelvic floor muscles. The pelvic floor muscle is almost like in this area, the pelvic floor. You can see this pelvic floor area, this perineal muscles or a urogenital diaphragm. So this at this area of vagina, you can see the at the upper one third, between the upper one third and two third, this pelvic floor muscles is seen. It's a muscular partition which separate the pelvic cavity and pelvic structure from the perineum. So there are three sets of muscle which is collectively known as the elevator ani group of muscle. Elevator ani group of muscle, like it mainly include the pubococcygis, iliococcygis, and ischiococcygis muscle is collectively known as the elevator ani. And even in it is like a curtain-like structure, there are mainly two openings. In two openings, three structures are passed from the like pelvic cavity into the perineum. That is one urethra, vagina, and rectum. You can see this vagina, and in front it may be urethra, and other back there will be rectum. The elevator muscles. So the pubococcygis means from the pubic symphysis it is attached to the coccyx, the pubococcygis muscle. Iliococcygis, in between this triangular muscles is known as iliococcygis. And this ischium, that is from the ischial spine up to coccyx, this muscle known as ischiococcygis. This pubococcygis muscle is again divided into two or three parts, like depending upon the muscle fibers surrounding it, it's again divided into some more parts. So these supports the pelvic structures. Another muscle is like perineal muscle. It is also the supporting it in the lower portion, this perineal area. This is the perineal muscles are there. Mainly you can see this is a triangular type of support is there. This is ischiocavernosus muscle, bulbospongiosus muscle, and also transverse perineal muscle. It can be a superficial and deep also. Deep superficial and deep muscles are there. So there are four muscles in transverse, a pair of superficial and a pair of deep transverse muscle. All these supports the uterus in position. If there is a weakness of these muscles, these support, it may cause prolapse. Now we will move to the fallopian tube. The fallopian tube is a structure, it's almost like a torture structure, that is a curved structure almost 10 centimeter long, attached to the corner of the uterus, and it has a connection to the peritoneal cavity also, and it lies close to the ovary. Its main intention is to pick up the follicles, pick up the dominant, like the dominant follicle, which after ovulation, this fimbriated end of the fallopian tube pick up the structure. So the fallopian tube is mainly divided into like three part: interstitial part, then isthmus part, then ambula. In the ambula, the fertilization occurs, and this is the infundibular part. In this part, it has fimbriated end, and the follicle is usually picked up from this area. So the main function of the tube is like ovum pickup and the transport of the fertilized ovum to the uterus. And it's also having some secretions and also cilias are there, which supports the flow. And the moving to the histology, it contains the mucosal layer, the muscular layer, and the serous layer also. And the clinical aspect is of that ectopic pregnancy. There is ectopic pregnancy means pregnancy outside the uterine cavity. Okay, it can be either in the interstitial portion or in the like in the isthmus portion or near to the infundibular portion. So, unlike the uterus, the fallopian tube will not stretch that much. So, there may be a chance of rupture if the diagnosis is missed. Next is hydrosalpinx. Hydrosalpinx means hydro means water, water which get filled in the fallopian tube. That is known as hydrosalpinx. If there is some occlusion, if there is some obstruction or occlusion in the fimbriated end, it can be due to infection or it can be due to endometriosis. If there is an inflammation and occlusion here, then what happened? This inflammation mediated cell response, there will be more secretion of the fluid from this epithelium, and there will be a less reabsorption. So more fluid is secreted and less reabsorbed, so the fallopian tube become more tortuous and like engorged. So the main function, like the pickup of the follicle, the fertilization, it all gets blocked. It may be a reason for infertility also. So even after the treatment of this hydrosalpinx also, the normal function of the tube is regained is little bit less, and there is more chance of ectopic pregnancy also, because of the it lost its normal like movement. The blood supply is contributed by the uterine artery and as well as ovarian artery. It drains into the right and left ovarian vein. Now we will see the ovary. Ovary of the female gonad, which lie in the ovarian fossa. The measurement of ovary should be known, 3 into 2 into 1 centimeter. And also volume is usually mentioned. In like PCOS patient, we can see the ovarian volume increases like 10 cc, 15 cc, like that is mentioned. And it is like placed in the ovarian fossa. The main function of ovary is steroidogenesis, that is production of hormone, ovarian hormone, and also the production of follicles also. So ovary is attached to the uterus, the corner of uterus, by the corner of uterus by the ovarian ligament, which is a part of the round ligament also, round ligament. This like a laparoscopic view. This is a laparoscopic view of the uterus. You can see this uterus. This is the round ligament. This is the ovarian ligament, ovary, fallopian tube. This is the uterosacral ligament. You can see it clearly. Intestine coils you can see. So ovary is on the laterally, it gets related to the ovarian fossa, and the structures which like fallopian tube, which cover almost cover the upper portions of the ovary, and hilum is the area where the ovarian vessels and nerves enter to the surface. Histology is mainly the ovary consists of ovarian cortex as well as medulla. The cortex is an important one because the cortex contains so many tiny primordial follicles. That is, so many seedling follicles are seen in the cortex. And also you can see the developing follicles also in the cortex. And another thing, medulla. Medulla is the innermost area. It contains so many loose connective tissue, blood vessel, nerves are also seen in the. And one more thing is it contains hilum cells. That is the cells which are in similar to the interstitial cells of testis. It is seen in the medulla as hilum cells. ovary with follicles, this developing follicle, like developing like primary, secondary, tertiary, graphene follicle, then ovulation occurs, then the remnant becomes corpus luteum form. So in certain patients that there will be developing of follicular cyst. Follicular cyst means this graphene follicle form, but it failed to ovulate and it remains like a cystic structure. And the follicular cyst usually disappear even without treatment after 3 months. It usually disappear, and luteal cyst also commonly seen in patients. So how the ovary reserve are formed? I had already mentioned that ovary contains so many primordial follicles. So during the embryonic development itself, the primordial follicles which are migrated to the developing gonads undergo rapid mitotic division. Mitotic division means multiplication. It gets multiplied into so many number. Like around 20 weeks, it reaches up to a 7 million in number. So after that, when it reaches after almost 22 weeks, it goes into meiotic division. So meiotic division under meiotic division and it reaches up to a particular phase, and it is covered by the flattened epithelial cells known as the prime, and then it is known as the primordial follicle. So these flattened epithelial cells are the future granulosa cells. So this protect the cell as well as its DNA also, because by a baby, a girl baby at her birth contains the enough follicles for the up to her menopause. So these follicles are usually developed after puberty only. So up that time it had to be preserved. The DNA and everything had to be preserved. So it is like a cryopreservation, like that. In the sleeping phase, it undergoes and preserved. So by birth, it reaches about 1 to 2 million primordial follicles will be present in the ovary of the baby or girl child. And when the girl reaches the around puberty, almost 4 lakhs is seen. So when there is a possibility of 400 follicles like to ovulate in the entire life of a female, only of this 1 to 2 million, only 400 is ovulated. The other become atresia. Atresia means or programmed cell death. This is an image like this embryonic development, primordial follicle and development. So the blood supply to the ovary is mainly by the ovarian artery, and the uterine artery also contribute to the uterine artery also contribute to the blood supply of the this ovarian function, and it's drained to the ovarian vein and lymphatics like the lymphatic para ovarian lymphatics. Then in like anatomically there is some difference between right and left ovary, and even the right ovary responds more to the gonadotrophic hormone, as the gonadotrophic hormone like from the hypothalamus, the gonadotrophic releasing hormone secreted, it stimulates the pituitary gland to secrete FSH. This FSH stimulates the ovary to produce the ovarian hormones like estrogen and progesterone, like in the menstrual cycle, like the follicular phase, ovulation, luteal phase, like that. In the first phase, estrogen is the primary hormone, and the second phase, the progesterone is the main hormone. So even it is both ovary respond equally, but clinical studies states that there is a 60% more chance of developing or like a successful pregnancy that the ovum or the follicle develop from the right ovary. So, and there are so many conditions related to ovary, like PCOS. We all know there are multiple developing follicles in the ovary. It is arranged in necklace pattern like that. PCOS is commonly seen. Another common condition is ovarian endometrioma. Ovarian endometrioma means there are chocolate cysts, there are cystic-like structure in the ovary. So these type of whether PCOS or ovarian endometrioma all interferes the normal ovarian function, or all interferes the normal ovulation. Thereby, the normal ovarian function or ovulation or pregnancy is impaired. Okay, we had completed most of our topic, and here ends the topic. Do you have any doubt? Hello?
Yeah, thank you, doctor, for the session. Yeah, just unmute all. So you can unmute and ask. Okay. Or you can bring your questions in chat box also.